Here's our scene management for patients with symptoms of emergent infectious diseases. This is version 1.0. We've made in late October of 2014. After multiple meetings with multiple agencies and agreed upon guidelines between public safety as well as in consultation with medical direction, public health, state health experts, 911 operators, hospitals, and consistent with the current but constantly changing guidance from World Health Organization, CDC, and other places. And obviously it's subject to revision. That's why we're calling it version 1.0. For our people, we get 4 things from this lesson. We're going to talk about improvements in PPE equipment, as well as a change in when we wear various PPE. We're going to talk about the addition of an infectious disease screening performed by 911 operators and then again by fire and EMS personnel, either of those screens could trigger additional PPE, additional procedures. And then we're going to practice donning and doffing this PPE and decon procedures. We believe this will benefit our responders through improved safety for all types of patients, particularly those with infectious diseases, not just Ebola, flu, and other things. And it'll give us an increased emphasis on situational awareness, something that we need to be constantly vigilant of for situational awareness, risk management, scene assessment. All these things that happen in the world can impact us at any time on any call, and we believe that this will bring some increased awareness there. And we also get some reps and increase our operational readiness for hazmat events. Our change in PPE. We're going to full level D on all patient contacts initially. Full level D is going to include having all skin covered with an N95 mask, gloves, and goggles. Once you realize and determine that the patient is not a significant infectious disease threat, then you may reduce that PPE as appropriate, but in any case, there'll need to be some explanation and discussion with the patient and family. We're going to change our current N95 mask to a version that's a little bit better. Better in that it's easier to breathe through and it stores better. The current ones are just as effective as the ones we're going to replace with. We're just looking for something that works better logistically with the way we do business. Eye protection will probably also evolve from glasses toward goggles. We need to have some way to get a seal on your forehead over your eyes and protect you from any liquids that may come down from your forehead or on your head. The other thing, after we talked about PPE, we said that we're going to deal with infectious disease screening. Joint Communications 911 operators are going to ask additional questions for patients who present with headache, hemorrhage, bleeding, or the general sick person sorts of complaints. They'll ask questions about, do you have a fever? Do you have certain symptoms? And then your travel history to West Africa. Fire and EMS will perform the same screen, but we're going to do it on all of our patients. We're going to weave it into our assessment as appropriate. Any patient that meets the criteria, whether the 911 operators screen them for it or fire and EMS screen them for it, if they meet those screening criteria, they're called something new. Our term is Caution Indicator 5. What does a Caution Indicator 5 mean? Well, it indicates that the patient fits the profile for symptoms of Ebola. Of course, it's an unconfirmed diagnosis, but we're suspicious of that, enough so that it's going to trigger additional practices on our part in terms of PPE. Joint Communications 911 operator screening will trigger an automatic notification of a number of stakeholders, including public health, an information, a notification, an alert, so to speak. And then once that is confirmed, the screening is confirmed by fire EMS, that will trigger a second set of notifications as well as automatic dispatch of hazmat resources, whatever that jurisdiction uses for hazmat. In our case, it'll be hazmat 514 and support 510. Public health will be dispatched and will respond to the scene. The duty chief will obviously be aware, and then that whole set of other stakeholders gets a second alert. What's the screening look like? Well, we provide cards for all of our members and public safety folks throughout the system here. These are based on CDC guidelines. They're aimed specifically at Ebola. However, they will help us catch flu and other viral infectious diseases that are out there. There's 3 levels. If at any point you get to a no, you can end the screening. If you get a yes to question 1, you move on to question 2. If question 2 is a yes, you move on to question 3. Question 3 is on the back of this card and talks about travel to the high-risk areas in West Africa. If all 3 questions are answered yes, then that triggers a caution indicator 5. Now, it's possible that the caller will call 911 and say right off the bat that I have Ebola. Unlikely, but possible. It's also possible that the 911 operator will then dispatch the call. In the second scenario there, dispatch the call for headache, for sick person, or some other complaint, and then do some further questioning and come back to us while we're en route with what we typically refer to as the further traffic, and give us that this is now a caution indicator 5. It's also possible that the communications operators will not be able to get clear information, or get inaccurate information, or get different information from what Fire and EMS gets when we do our face-to-face screening. If our screening triggers, if our screening is positive, then that also triggers the caution indicator 5 process. Our patient care does not change. We continue to deliver patient care just to the same level as we always have. We simply add some protective measures for us, and we use some common sense. The area around the patient, the 6-foot area around the patient, is deemed higher risk than other areas. We call that the action circle. And we will enter that action circle when we need to provide care or to do assessment, but there's no reason for us to routinely be in that action area unless there's something that we can do in a positive way. Once indicator 5 has been triggered, then additional personnel will enter the scene, replace those that are those of our folks that are already in the scene, and the replacement crew will come in a level C suit with a full face air purifying respirator, using our SCBA face pieces with the air purifying respirator canisters added to that, wearing our fire boots, and at this point double gloved, but not necessarily taped. Now, I said that this was version 1.0. There's some evolving things. The glove piece of this ensemble is likely to change or be modified in some way. We already have appropriate PPE for these sorts of events in the hazmat kits on our engines. We're going to add them in the following configuration here, in these orange buckets at this point. And we'll be adding additional PPE kits to our grass rigs, who we send on most medicals, as well as the tankers. So any apparatus will have this equipment there. The trash bags at the bottom have dual role. One of them is in the decon process, and a second is for us to isolate that ambulance cab. We'll talk about that more here in a little bit. Indicator 5 zones. Nothing new here except the action circle. The 6-foot area around the patient is the action circle. We deem the hot zone to be anywhere in the patient's dwelling, anywhere where they have been, where body substances are likely to have been exchanged with surfaces. The warm zone then would make sense to be immediately outside that, and the cold zone further out. Once an indicator 5 call is dispatched or an indicator 5 is declared, fire units will implement level 2 staging. That's a key point. Law enforcement will respond, media will likely respond, and the destinations at this point are designated as the University ER and Women's and Children's ER. That is another piece that may change as we evolve here. So our members should stay tuned, stay in communication with your station leadership, check emails, be up to speed on what's going on. It's unlikely that a plan that you put in place for something like this will last as it was first put out. We'll need to make some changes. Indicator 5 actions. What has to happen if once an indicator 5 is declared? Anybody in the hot zone is in level C. We're only going to put 2 of our members in that hot zone in most cases, unless there were to be some extraordinary circumstance. And once we're in that hot zone, we expect that 1 will remain just outside the 6-foot action circle, while 1 remains quite a ways back in a contact and cover sort of format that we use on all of our calls. The EMS crew will enter the hot zone, and they will interact with the patient in the action circle. We're going to limit equipment that we need to bring in, and limit equipment as the medic units will as well. Limit equipment to that is needed to give emergent or life-saving care. Common sense needs to prevail. We need to slow down in general and think of what we're about to do is going to make a difference for the patient or just create additional hassles down the road. Indicator 5, scenes. Fire department will act as a communication aid for the medics. The medics will be in with the patient in the hot zone and will not be having access to their usual cell phone communications. We would like a lot of the communication about these events to be handled via telephone. We'll need to position the ambulance as close as possible to the scene, to the route of egress from the house, maybe closer than we usually would. We want to limit the amount of potential contaminated area that needs to be deconned. We will provide a driver. We will use plastic to isolate the cab of the ambulance from the patient compartment of the ambulance, so the cab is technically a warm zone, and we'll put one of our people in the front seat to drive, and that person will be in a level C suit, but will not be actually wearing the level C respiratory component. They'll have their face piece with the canisters ready to don if they need to, but really they're to drive the ambulance safely, and that would not be as safe with the face piece on. And secondly, they are a rapid intervention, a RIT team. Should something go wrong in the patient compartment, they would be able to properly protect themselves and then intervene to assist. Fire department's going to handle decon of fire department staff. Hospitals are going to handle decon of hospital staff. The hospital will also take care of deconning our driver. Now, our driver will, in almost all cases, not be hardly contaminated at all and may have a theoretical exposure, but we'll also be involved in assisting with that decon at the hospitals. Speaking of decon, this is another area that's an evolving concept, and I expect it to change, and I expect that we will have ongoing training and ongoing revisions to policy. We're looking at all kinds of options, including some disinfectant wipes, some sprayers with various substances that will kill these bugs very quickly, spritzer bottles versus garden-type sprayers, and then, of course, if all else fails, we have the Merlin compressed air foam system unit that's on one on our hazmat truck and one that's been loaned to City Fire. And these are compressed air foam decon units that come to us through the USAR Missouri Task Force cache and are really optimal for large areas of decon and high volume decon, but it generates a decon foam. The key thing here with decon is that we need to make sure that we don't make a bigger mess than need to, and so any liquids and such will need to be absorbed and contained. And so this is an evolving thing that we're working on at all times. It's standard decon, same sort of steps, same sort of process that we all know. The case here is more simple in that it's a known substance and we have a known way to neutralize it. So to wrap this up, it's an evolving situation. We know that things are going to change. We only care about getting this right. We're trying to distribute our information widely here so that a number of people can look at it. If you see something, say something. If there's something we can do to make this better, contact us directly at the office, through EMS education, through your station leadership, through fire district leadership, in any way you can. Bring your ideas forward, bring your questions forward, and stay tuned for further.